Oh, that. We talk about.
I've put you back as host.
Mm.
Oh, yeah, I can see that. That's fine.
Yes, and we're live.
All right, no problem. I'm going to make you
So
co-host now.
I'll send out the links on. I'll keep the link so that people don't start joining when we are not ready.
I think you should keep it till when we are at
I'll put you
capacity.
back as host.
Yes, I know. I said keep the link till when we are at capacity. Oh, yeah, I can see that. That's fine.
Yes, and we're live.
All right, no problem. I'm going to make you co-host now.
I'll send out the links on. Should be so loud.
YouTube.
You guys should keep quiet. Good evening, sir. Dr. Saimi.
Good evening, Ma. Good evening, everybody.
Yes, sir.
Nice to hear your lovely voice. Well done.
Same here, sir. I was still talking about it today at work. I'm prof.
Okay. That's
Yes, sir.
nice.
Yes, sir. Dr. Sadiq was here earlier. I think he came out. But I think, sir, maybe you want to share your screen
Okay.
to test it.
Dr. Sadiq said
Yes,
what?
sir. No, I'm saying that this
Okay.
Dr. Sadiq was here, but that he's not here right now.
Oh.
And I was just suggesting that
Okay,
you share your screen.
Oh, he's saying sharing
Sir?
is not turned on. I need to send requests. You are the co-host, so you make me.
Oh.
Good evening, sir. You can share now. Good evening, sir. It's Cyril.
Okay. Yeah. We can see, you can see the slide now, right?
Oh, okay.
Dr. Tokes.
The slide is visible.
Okay, thank you.
We can see your screen. Yes, we can see, but it's not on slideshow.
I know.
And you are breaking up slightly, sir.
Oh, my voice is not clear.
No, you're clear here.
Like it's clear right now, but sometimes it acts like it's.
Dr. Tokumbo, is your own end, it's not my end. You are also
Okay, sir,
not.
your voice is clear now.
It's actually clear.
Prof, good evening, ma.
Good evening, everybody. Good evening, Dr. Sarimi. We are all eagerly waiting for you
Good evening, ma.
to discharge this stuff.
You want Omoshe to discharge stuff. Okay. Oh. Thank you for the opportunity to speak.
Please, let's remind them again on the GSM platform that we are live. We are on. They should join us. Just 2 more minutes. Yeah, we can see your slides.
Okay, ma.
No, but it should be bigger than this. Is it my phone? Okay.
I've not made it full screen.
Okay.
Good evening, Prof.
Is that serious?
Please, let's call
It's
Dr.
me. Good
Sadiq.
evening. I
Dr.
was
Sarimi,
trying to
can you
get your
call Dr.
attention
Sadiq
earlier.
to join?
Okay.
I think
Dr.
Dr.
Cyril,
Tokumbo.
can you change my name on the other post?
Okay, I will do that.
You can change to your name.
Okay, I'll do that. Dr. Tokumbo was also act as the stand-in anchor for the program. She's also out.
Dr. who?
Dr. Tokumbo. Okay, she's back. Okay,
My internet is bad though, Dr. Cyril.
Yes. Dr. Sadiq is also out. I have enabled
Please,
the
can we
waiting room
call him?
temporarily.
Let
so
them
that,
come in now.
And we need to sort out our technical issues before I let them in.
Let them in. Please, they will get discouraged. Let them in.
Okay.
Let them in. Because it's 6 o'clock, we said. Let everybody in.
What shall I do with my internet now? God.
Lay hands on it.
I can hear me. God. Hello? Can you hear me? Am I
Hello?
audible?
No, yes, I can hear you.
Oh, okay.
I can hear you.
Okay. Good evening, everyone, and a very warm welcome to this webinar. The moderator for the webinar is Dr. Sadiq, and he's trying to get in. Once he gets in, he's going to take over from me. But since it's 6 p.m., I think we can.
I'm here.
Oh, okay. So I'm handing over to you right away, Dr. Sadiq. You're welcome.
Yeah, thank you very, very much. Sorry, I had some technical issues here. And we welcome everybody to this once again interesting webinar from Glaucoma site. Without taking much of your time, I will invite our guest speaker, who is Dr. Torella Sarime, who is a consultant ophthalmologist and glaucoma specialist from University of Ibadan, University College Hospital. You're welcome, sir.
Thank you very much, Dr. Sadiq, sir. Thank you, everyone. Thank you to the Nigerian Glaucoma Society giving me this opportunity to speak on this topic to my senior colleagues and fellow colleagues. I hope at the end of this discourse, we would have been able to gain from both sides and the current management and future prospects with regards the care of juvenile open-angle glaucoma. So the topic is juvenile open-angle glaucoma advances and management tips. I hope at the end of my discussion, we'll be able to have mentioned what JOAG is, discuss pathophysiology, diagnosis, and management, and highlight the recent advances and a few tips that may be beneficial to us. Follow this outline. I will introduce by saying juvenile open-angle glaucoma is referred to as a subset of primary open-angle glaucoma, adult onset open-angle glaucoma. It's a rare form of glaucoma generally, and but it has been shown to be slightly more common amongst Africans and African descent, those persons from South Asia as compared to Caucasians. The age bracket for diagnosis of juvenile open-angle glaucoma has been shown severally to be varied. Some authors have put it between 10 to 35, others 10 to 39, some as little as 3 to 39. But the Childhood Research Network came together and brought out a consensus, and they put an age range of between 4 to 35 as the age range for which juvenile glaucoma can be diagnosed. But typically, for someone like me, I stretch it to 39 years of age. And the reason why they chose 4 as the lower limit is because they want to give room to possibility of having a primary congenital glaucoma occurring. We know after the age of 2, the typical characteristic of primary congenital glaucoma may not be present if it's at that time that the disease condition is occurring. It is usually bilateral in nature and has a strong familial connection. So by way of epidemiology, juvenile open-angle glaucoma in the United States has been shown to present in 1 in every 50,000 individuals. In other climes, some prevalence studies have been reported in clinical settings, and some other epidemiological studies, like a study from Nigeria, puts the prevalence among all forms of glaucoma, giving juvenile glaucoma to account for 3.4%, in India 3.3%, and among Caucasian generally 0.7%. You can see much higher prevalence amongst other regions, Africa and India, as compared to Caucasians. Genetics in juvenile open-angle glaucoma, it is said to be heterogeneous in terms of geneticity. There is not a monogenetic disease condition. It's typically considered an autosomal dominant disease with variable level of penetrance and expressivity. However, autosomal recessive and even sporadic occurrence have been reported, cluster of family and ethnic groups. In terms of the gene that has been expressed and related to juvenile glaucoma, the myosin gene is said to be the main gene that has been shown to relate to the condition of juvenile open-angle glaucoma. And this myosin gene mutation is a mutation occurring at position 24. Some authors say position 23 to 25 of the long arm of chromosome 1. Myosin gene mutation has been shown to be present in about 10% of primary open-angle glaucoma, but for the juvenile open-angle glaucoma subset, there's a higher rate of occurrence, about 20 to 30%. Its inheritance is autosomal dominant, and what does this gene generally express? It expresses myosin protein, which is abundant in the trabecular meshwork. So, and this myosin protein helps regulate the outflow of aqueous from trabecular meshwork. So a mutation here will cause dysfunction. So that mutation leads to accumulation of misfolded myosin protein, which causes trabecular meshwork dysfunction and increased outflow resistance. Other associated gene that has been other associated gene that has been linked to juvenile open-angle glaucoma, but far less common as compared to the myosin gene, include the CPAN D8 gene, which has been shown to be a gene responsible for anterior segment development, and a mutation here will cause anterior segment dysgenesis. The CPON-B1, that's the cytochrome P450 B1 gene, which is much more common as a gene of expression and pathology in primary congenital glaucoma, has also been shown to be less frequently associated with juvenile glaucoma. Now, the cytochrome P450 gene, as well as the latent transforming growth factor beta binding gene, when they are responsible for juvenile glaucoma, has been shown to be related with very high intraocular pressure in them. The optoneurine gene, also very less common, and the tank binding kinase protein, very, very less common, has been shown to be related to some form of juvenile glaucoma, but they tend to have a normal or low, high pressure in this category of individuals. Now, this is just one or two studies that has given us the relationship between myosin mutation and juvenile glaucoma. Now, this study is a mutational spectrum of myosin gene among familial versus cases of juvenile open-angle glaucoma by Gupta et al. And here they wanted to find out the expression of the pathologic gene in familial cases of juvenile open-angle glaucoma and sporadic case. And their results showed that while the mutation gene is found in 27% in familial cases, it's only found in 2% in the sporadic case. The p-value of a very high significant value shows the inheritance pattern of juvenile glaucoma and myosin gene. Now, this study, it's a Nigerian study, prevalence of myosin mutation in a cohort of patients with juvenile open-angle glaucoma from sub-Saharan Africa by Olawi et al., published recently. And we found in this case control cohort the prevalence of pathogenic myosin mutation to be about 8.9% in this population. So what's the pathophysiology of juvenile glaucoma? The definite pathophysiology cannot be ascertained, but there are hypotheses and theories, and there are links to suggest that disruption of aqueous humor outflow at the level of the trabecular meshwork is the main problem. And genetic predisposition, like the myosin gene that I explained earlier, and its relation with accumulation of misfolding of this myosin protein at the level of trabecular meshwork, is a major cause of elevated pressure and subsequent damage to the optic nerve head. And some persons have been able to phenotypically subclassify juvenile glaucoma to 4 groups. And this phenotypical classification is based on the angle appearance, the anterior chamber angle appearance. Group 1 is referred to as those whose anterior chamber angle has normal features. So they have normal angle and iris. And these tend to present or is seen in older age group of juvenile open-angle glaucoma. So maybe those in their 20s or 30s, they are the ones that tend to have this kind of angle morphology. Group 2 is said to be having a featureless angle, just a bland angle. There's really no typical structure. You cannot delineate the trabecular meshwork or things like that. So in this featureless angle structure, they tend to occur much earlier, very close to the primary congenital glaucoma bracket of glaucoma. And in this case, they have the earliest in forms of presentation. Group 3 are those with prominent iris processes or high iris insertion with normal iris pattern. This group of individuals tend to have higher intraocular pressure compared to the earlier two, while group 4 are those who have these prominent iris processes or insertion, but with prominent iris crypts, and their morphology tend to resemble maybe a subtle form of azenpharyngeus anomaly. And these people are the ones that tend to have the highest of intraocular pressure. Usually their pressures are in their 40s or even more than that. So clinical feature history is very typical because of the high level of inheritance and abilities. Finding about positive family history of glaucoma in parents or sibling is very important in this category of individuals, and it's possible to have that. Symptoms, usually they're asymptomatic in the early stages. It's usually in the advanced case of the disease that the patient becomes visually symptomatic. However, occasionally, patient may have progressive myopic shift in them because there's high relationship between juvenile glaucoma and myopia. They may occasionally have headaches, ocular aches and headaches when they have very high intraocular pressure. Rarely they may have photophobia. Occasionally they may also have halos when the pressure also is very high because of corneal edema. And typical presentation pressures are usually above the 30s or 40s, but that does not exclude having a lower pressure than this. Slit by examination will give you to rule out possible secondary causes. You want to look out for signs for anterior segment degenesis as seen as a Pharyngeal syndrome, for example, such as posterior embryonal toxins and things like that, which will be absent in this category of individuals. Gonioscopy needs to be done to look at the angle structure and look out for obvious secondary pathology if present to be able to exclude that. And of course, optic neuropathy present by the glaucomatous damage that is seen in them. Visual field changes is typical as it presents in any form of glaucoma. The typical arcuate, nasal steps, or paracentral scotomas are the normal findings. However, because of the age variation in this category of people from very young age to young adults, sometimes visual field cannot be carried, especially in the younger age group. For example, an 8-year-old with juvenile glaucoma will most likely not be able to carry out the visual field testing. So for the younger age group, may try to do a different strategy. Instead of doing your sitter standard, I may do a sitter fast or a sitter faster strategy, because this kind of also have a category of individuals have short attention span. The younger they are, the shorter the attention span generally. So you want to do test strategy that is very short, that may give them occupied and focused during that time of the test. Pachymetry is important, but in terms of its influencing glaucoma calculation and the rate is less as important as seen in adult onset primary open glaucoma. OCT is also important for documentation. Sometimes where visual field cannot be done, OCT may just be the only thing that can be done. So we have a structural evidence to show, even the fundus photograph. Of course, refraction, sequential follow-up is key because of their relationship with myopia. So after evaluating and making a diagnosis, and the patient is in front of you, what are the various treatment strategies that are available to go forward with? We have medical management in front of us, but it's important that I need to spell it very clearly, that medical management is usually a temporal measure to lower intraocular pressure while awaiting a more definite intervention, which is usually surgical intervention. And when you want to even choose medical treatment for the short while, you have to take into consideration the most efficacious of the medication. You want to take into consideration the one that will improve compliance as much as possible. So applicability must be simple and straightforward. And you want to choose one that has the minimum of side effects, especially avoiding systemic side effects. So having this in mind, the prostaglandin analog is the best choice to start with, either as a single medication or in combination drug. In either way, a single drop daily, it's better than having several drops that you use severally. And since it's most times used for a short period, you may even have a short course oral medication in form of Diamox until the definitive treatment is given. Once again, medication is not a long-term treatment option for this category of people because of their life expectancy, problem with compliance, dependent on the family caregivers and the rest for provision of some of these care, medications and the rest makes this not an option for long-term care. So challenges maybe to run through this because I've said that already. So in terms of treatment, surgical advances, we start with the traditional treatment. Up till now, the gold standard for managing juvenile open glaucoma is trabeculectomy. Trabeculectomy with antimetabolite. And that is even more sacrosanct in African eyes with our attendant problem. Antimetabolite is a must amongst us. And the reason why trabeculectomy is the choice here is because of this highly efficacious in terms of reduction in intraocular pressure and fact that you may have longer or prolonged success rate amongst them with proper post-op care of the bleb. And of course, with the use of antimetabolite, that improve the success rate with them, even though we know that they have a higher fibrotic responses in this category of individuals. So, but we still have challenges, even though it's supposed to be the gold standard. We need to understand because of the higher risks of scarring and failure in young people, the post-op bleb management must be top-notch in terms of anti-inflammatory medication use, in terms of early intervention with maybe subconjunctival antimetabolite 5-FU or mitomycin C, or even earlier removal of releasable suture. For example, if I operate a dual patient, by the first 1 week post-op, pressure is 10 or 11, I want to remove my first of the 2 releasable suture. I want to keep that pressure as low single digits or very low teens as much as possible. By doing that early, improve outcome generally. The second surgical options available are the tubes or the shunts. And their indications includes from field trabeculectomy, presence of extensive conjunctival scarring, or occasionally maybe a primary surgical option for the patient. And we know the mechanism basically creating an extra ocular reservoir for which the fluid drain through. And predictability in terms of IOP control slightly better than trabeculectomy because it's less dependent on patient healing response as compared to trabeculectomy. However, I see has own disadvantage. We have early hypotony, especially in the non-valve glaucoma generating device, but with the use of stents and appropriate ligation, this hypotony occurrence is reduced significantly. But the long-term problem include things like tube erosion, diplopia, strabismus, and these are some of the problems that the individual may have with having the tube in situ. Aside from the aforementioned 2 surgical options, we also have minimal invasive glaucoma surgeries, and they're also gaining traction. Basically, what minimal invasive surgeries are, they give you opportunity to be less invasive. They have internal in approach, so as much as possible, they preserve the conjunctiva for future other surgery if needed, faster recovery rate following surgery, and less complications from them. Now, what role specifically does minimal invasive glaucoma surgery play in juvenile open-angle glaucoma patient? Need to understand because of the proposed pathophysiology of trabecular meshwork resistance. Any minimal invasive glaucoma surgery that can bypass the trabecular meshwork will improve intraocular pressure control. So, minimal invasive glaucoma surgeries that have that ability are the ones that should be considered. But we also know that their intraocular pressure drop is not as low as that of trabeculectomy or glaucoma generating device. Hence, they are more appropriate for early to moderate juvenile glaucoma if they are prescribed. So some of these minimally invasive glaucoma surgery includes gonioscopy, assisted transluminal trabeculotomy. In this case, a 360 degree unroofing of the Schlemm's canal creates a direct access of the aqueous humor to the Schlemm's canal, bypassing the trabecular meshwork completely. And this has efficacious show of reduction in trabecular pressure. We also have the KDB goniotomy, that's a Kahook dual blade goniotomy as an option. This removes a section of trabecular meshwork, not 360. It removes approximately 120, but can stretch it up to 180 degree of the trabecular meshwork can be deroofed by using the Kahook dual blade and goniotomy. It is simpler, efficacious, cheaper than the illuminated GATT system. However, few studies that have been done comparing GATT and Kahook dual blade shows that the GATT is more efficacious than the Kahook dual blade. And for obvious reason, one deroof 360 degree, the other deroof approximately a third of that. So it's expected that that may be the outcome. But in a resource restrained setting like ours, where even this Kahook dual blade can be quite expensive, we can use the bang instead of using the Kahook dual blade. And the bang is actually the bent ab internal needle goniotomy. So we can do that bang, bent ab internal needle goniotomy. In this case, a 25 gauge hypodemic needle is bent and is used to deroof the trabecular meshwork in the same fashion as using the Kahook dual blade under a direct gonioscopy. The key here is that should be proficient in performing direct gonioscopy in theater. Other mix that are also possible to be used include the ab internal trabeculotomy devices like the trabectome, omni surgical system, or the stents, the eye stents, and the rest. So aside from the first three I've mentioned, as trabeculectomy, shunt devices, mix, lasers too as a surgical option, and selective laser improve functionality here and increases outflow. There's no permanent damage, so it is repeatable. What's the role of SLT in juvenile local angle glaucoma? It can be considered one as a bridge to having surgery or to reduce the medication burden, or can be a standalone first line intervention in patients with early to moderate juvenile local angle glaucoma. Of course, it shouldn't be a first line treatment for someone with advanced juvenile open angle glaucoma. The limitation here is that the long-term studies, one, are not available for us to prognosticate the long-term efficacy of them, and then the younger patient may not actually be as beneficial to SLT as the older juvenile open angle glaucoma patient from little studies that have been done. Cyclophotocoagulations are also an option, more reserved for refractive cases. Those who have had multiple surgery and yet suboptimal pressure control may offer them that as an option. So what is the long-term management and follow-up for this kind of patient that we are dealing with, patient with juvenile open angle glaucoma? We need to understand that care of glaucoma, generally, we all know that it's a lifelong monitoring. And for this category of people whose glaucoma occurs at a younger age, lifelong expectancy in them is much longer. So the follow-up period is actually much longer. So for this kind of individuals, they need to have an understanding of the chronic nature of the disease, the progressive nature of the disease, and the need for constant follow-up to ensure that we halt progression as much as possible. Regular examination is key. After surgical intervention, the frequency of follow-up should even be much closer to pick early signs of failure, impending failure, and intervene appropriately to maximize outcome of surgical intervention that one has done. Investigation should be done serially, monitor refractive states, myopic patients, And for very few patients on medication, maybe post-op medication, side effects also be taken into consideration. So management expectation or managing expectation. We need to bring patients' expectation to care reality. So patient and family expectation to care reality must be merged. So education is key. Educating patients and family members about the chronic nature of juvenile open-angle glaucoma, the need for multiple intervention of this being possible over the trajectory of their life is also something that they should have at the back of their mind. And the goal to for them to note that our aim is to preserve vision by halting progression and never to cure the disease is also very key. Why this is more important, but we're dealing with younger people, maybe a juvenile glaucoma of a 10-year-old. So the caregiver, the family, or the parents are even much more important in counseling at that stage for them to understand, because care is being provided by substituting responsibility. So they need to be carried along properly. Addressing psychosocial aspects is also key. The impact of education, care, career choices, quality of life. And for example, we know medication use will really affect quality of life of such individuals. So one of the other reasons why it shouldn't be considering medication as a life long-term intervention strategy for this category of people. Refer to low vision services if needed for those who have the low vision already. Psychosocial support for patients and parents, having counseling session if you have that opportunity in your clinic facility to do that. Encourage family screening. This is key. Encourage family screening because of the familiar nature of most forms of juvenile open-angle glaucoma, so that it's possible for either picking the disease early or even genetic screening and genetic typing if the facility is available. Look at those who don't have it, may have a higher risk of having the glaucoma in their lifetime. So what are the advances and future therapy available for care of juvenile open-angle glaucoma? We have things like gene therapy in juvenile open-angle glaucoma, myosin targeted therapy. For this gene-based therapy, shows promise, right? But at present, the study is at the rodent level, that is mice level, whereby some medications like the trimethylamine N oxide, TMAO, as a natural osmolyte, has been applied to cause unfolding of the folded myosin protein, for example. And this gene therapy can actually be applied or delivered through topical medications or by injection. All these are in the investigative stage. Stem cell therapy potential is also there, whereby we know with stem cell transplant, there can be regeneration of the trabecular measure, the primary source of concern. By stem cell transplant and its feasibility and outcome is quite difficult for retinal conditions because of the complex nature of the retina. The trabecular measure is less complex, showing prospects, but is still in the infantile stage of study, in the sense that the study now is at the rodent level. The next level is to look for animals of close proximity to human primates, that for which you can do this stem cell transplant. But that's actually ongoing. Neuroprotection strategies are different from either in drops or in medications are also there as an option for the long run. Novel drug delivery system, either sustained release implant through the punctum or through injectables into the anterior chamber of the vitreous for 6 months, or 3 months, 6 months, or even 9 months. Sustained release injectables are available. Options also include contact lens drug delivery system. Now, these systems are not peculiar to drug, but are peculiar to all forms of glaucoma. Artificial intelligence in glaucoma is also something that is being investigated serially to improve the screening and diagnostic package for this category of, and especially for dual patient, whereby the high familiar risk is there. So giving opportunity for family members to be screened early from remotely, and appropriate computing from AI will help give an initial diagnosis and send for confirmation at the base center. Predictive modeling through statistical modeling can also be used to improve the quality of the AI diagnosis over time. Teleophthalmology for monitoring someone who has been diagnosed to have juvenile open angle glaucoma, but because of their highly mobile, these are the workforce age group of the population, either in tertiary education, tertiary studies, or working. This kind of people will benefit from remote IOP monitoring devices, which may be at a primary base center, and their severity of glaucoma may have been computed in such a way that they have a score, the IOP value above this will send a message to them to have their eyes checked with the ophthalmology glaucoma specialist or something like that. Home visual field testing, for example, self-testing opportunities are there, just like the ionic device that you can do your visual field using the laptop or a desktop at home, and the result is automatically transmitted to the base hospital for storage. And when this individual come much later, a serial visual field is available for the clinician to review. Emerging biomarkers for JOAGs are also being investigated through aqueous humor analysis and genetic panels. These are all at their rudimentary stage, but they are things that are being worked on presently. So I have basically two case studies to round up my presentation with. The first one, my patient, a 23-year-old female, diagnosed to have glaucoma a year prior, presented to us June 2024, that's last year. She came to me because her mother is my patient, being treated for glaucoma. And when the mother told her about the need for screening, she screened at a facility and she was diagnosed. And she was diagnosed two months prior, 2 months prior to her presentation to me. And at the point of diagnosis, I was told her pressures were 26 and 28 millimeters of mercury, and she was started on prostaglandin analog at that facility. At presentation to me, her best corrected visual acuity was 6.5 in both eyes. Angles were open, relatively normal anterior chamber angle structure. Intraocular pressures at then were 13 millimeters of mercury in each of her eyes. A fundoscopy revealed small size discs, a vertical cup to use ratio of 0.4 in the right eye and 0.45 in the left eye, with presence of inferior rim thinning in both eyes, so isn't truly violated in her. Central cornea just marginally borderline thick, and these are fields, normal fields. An impression of pre-perimetric juvenile open glaucoma was made, but in this situation, because of its very early stage, she's quite young. I won't keep her on medications. I offered bilateral selective laser trabeculoplasty last year, that's June, that same month that she presented, and we discontinued prostaglandin analog. She had 4 post-SLT visits since then, and the pressures had been between 12 and 13 millimeters of mercury in both eyes. Our last visit was 2nd of May this year, with pressures of 12 in eyes. Case 2, advanced juvenile open glaucoma, a 17-year-old female undergraduate who had been diagnosed in a previous center 9 years, a different facility 9 years prior as juvenile open glaucoma, and since that time was placed on anti-glaucoma medications, and has been changing medication back and forth. There's a positive paternal grandmother having glaucoma in the family. At the time she presented to me, she was on 3 anti-glaucoma medications. Uncorrected visual acuities were 6.9 partially in both eyes, but the refraction was 6.5 in both eyes. Intraocular pressures were 16 and 17 in the right and left eye, respectively. The angles were open. A cup to this ratio showed advanced disc damage, 1.0 and 0.95 in both eyes. These are fields. The left and the right eye, you can see the advanced field, double aquate field loss with mainly central island of vision. So an impression of bilateral advanced juvenile open glaucoma was made as at 2023, just 2 years ago. She was booked for bilateral trabeculectomy with antimetabolite, right eye first. She had the right eye on the 12th of September 2023. And for the next 18 months of follow-up, the right eye, which she had the surgery, her vision had remained good. Intraocular pressure had ranged between 7 and 10 millimeter of mercury. The left eye, which she remained on medication, had been between 11 and 17. And why was this delay between the right eye and the left eye surgery? Because of our school commitment, they did not commit to come for second surgery until they came recently. This is a field which was done last month, 20th of June, right, left eye, right eye, 10-2. And she now had the left trabeculectomy plus mitomycin C on the 24th of September, barely a month ago or 5 weeks ago. And at the last follow-up visit, which is the 17th of this month, that's the right eye 22-month post-trabeculectomy and left eye 23 days post-trabeculectomy. Visual acuity are fine, diffuse bleb in both eyes, intraocular pressures 10 in the right and 9 in the left. Plan is to continue post-op care in the left eye. She's not on any medication in the right eye, practically 2 years after surgery. So key takeaway from my presentation, juvenile open-angle glaucoma is a rare but aggressive form of glaucoma that presents in young individuals, often with a strong genetic component. Early detection through regular screening in high-risk individuals, that is those who you have identified to have a family history of glaucoma, is crucial to prevent irreversible blindness. Management requires lifelong multimodal approach, combining medical laser surgical therapy, but the key here is surgical intervention with others as add-on, surgical in form of traditional surgery or laser, depending on the severity of the disease. Recent advances include new medications, minimally invasive glaucoma surgery, and gene therapy at the rudimental stage. Patient adherence and regular monitoring psychosocial support are critical for long-term success and quality of life. I will summarize by saying, understanding that JOAG is said to be a subset of primary open-angle glaucoma, or a bridge between primary congenital glaucoma and primary open-angle glaucoma, which is said between 3 to 40 years. It is more severe and faster progressing than the conventional adult POAG. The pathophysiology has been linked to dysfunctional trabecular meshwork. Management strategy, you may start with laser or medication, but you have to escalate to surgical intervention as the mainstay of care. Novel drugs, MIGS, and the rest are recent advances in the care of juvenile open-angle glaucoma, and educating patients and family members for them to have an understanding and agreement between their expectation to the reality of the state of their eye and care is an important component in long-term success in their management. Thank you for listening.
Thank you very much.
Thank you very, very much, Dr. Terela, for these great presentations. You have said so many things, and it's really educative and all that. So we have some questions from, it's already in the chat box. Can you hear me? Hello?
I can hear you.
Yes.
I can hear you. I want to open that.
Yeah.
Okay, the first question here is that thank you very much, sir, for the lecture. Sorry, can I go on? I can barely hear you, Sadiq. Okay, I think I should read out from Dr. Ibrahim. Said, what is or are factors that determine which surgical management option to explore for a patient with juvenile open-angle glaucoma? Like the two case scenario I gave, someone with Hello, am I audible?
Yes, you're audible, sir.
I can hear you, Sarimie, but Sadiq, we can't hear you, Dr. Sadiq. But we can hear you, Dr. Sarimie.
Okay, so let me continue. So was asking what factors determine which surgical management option to explore for patients with JOAG. There is a cascade of what do you want to achieve? How low do you want to set your target intraocular pressure? And factors that influence setting target intraocular pressure includes the severity of the disease at presentation, the baseline intraocular pressure, the age of the patient. So you want to use all those things to decide on which option to give first. The two case scenario I gave, for example, case scenario 1, early glaucoma, practically pre-perimetric glaucoma. That kind of patient, I want to give a milder option at first and follow up appropriately. And that's why I used SLT to manage the child, the young lady. As against the second one, who has advanced glaucoma, very advanced glaucoma presentation, had been on topical medication for 9 years. Definitely, surgical intervention in this case will be the traditional trabeculectomy. And if you want to go a step further, you may also want to consider a glaucoma drainage device, but you have to weigh the risks and the benefit in each case. So there are so many factors. I mentioned the age, severity of disease, intraocular pressure, what is your target you want to offer. Now, with the advent of MIGS and their a possibility of doing cheaper MIGS, if you have early glaucoma, early juvenile open-angle glaucoma, try SLT, and if that's not successful, you may try a MIGS first before you go ahead and do your traditional trabeculectomy surgery. But this is also based on the availability of the various options. But if they are not, and you are just stuck with your traditional trabeculectomy, please still go ahead. That is still the gold standard, even according to the Nigerian glaucoma toolkit. Second question, how would you manage a JOAG patient, 13 years old, this both ties, but controlled with PG analog and dosot combination at 12? Will you advise? Definitely straightforward. This patient should have a trabeculectomy surgery. Even though at face value, with 3 anti-glaucoma medication, pressure appears controlled. But for how long do you want to keep this patient on this set of medication, especially that you know that over time, the medication stimulates subclinical conjunctival inflammation that reduces even the risk, the success rate of your conventional surgical intervention later. Looking at all this for advanced juvenile open-angle glaucoma that will need 3 drops to control pressure, surgical intervention in form of trabeculectomy is the key, primarily. Please throw more light on, the Mausilin targeted therapy. It's still at the rudimentary study at the rodent level test, whereby some specific medication that have been shown to help unfold the protein itself. It can actually help to improve outflow, or actually what's it called now? The CRIPS gene therapy, whereby you modulate and change the defective gene, and in that case, subsequent expression of the protein by that gene is no more mutated. Those are some of the things that they are looking at presently. Thank you, sir. What are considerations for age match normative data in doing CVF and OCT in younger JOAG patients? Now, that's actually a bone of contention, especially for the OCT, where for most OCT, the least age of entry is 18 years. Those who are younger than 18 years, and you put the real age of the individual, it shows your OCT without a comparative value, no normative comparison. However, it is suggested, there's no general consensus to this, suggested that for such people, you put the baseline age of 18. Say, for example, the individual is 14 years, and you put the baseline of 18. So whatever performance he has, it will be compared to a normative data of an 18 years old. And we know if there is significant defect, it will be obvious, because it's expected for a younger person to perform better than an older person. Generally, that's the linear relationship between age and performance of these tests. So if we do that, if there is an obvious defect, it will peak. It may miss very subtle one, which you should not cry over. And what you do in such situation is to follow serially. The other option, if you don't want to do that, is to use the patient age and monitor based on the patient's own performance over time. Those are the options that you can do in this test that doesn't have appropriate age for younger people. How do you counsel a drug patient to accept travel, especially patient has a family member who had similar surgery and became blind thereafter? You just still have to try and counsel. The key, like what I tell my patients at first visit, after explaining the situation, the severity of the disease, the natural progression that will occur if left untreated, and the options available and the available success rate. After explaining that, I give such individual opportunity to go and read more and come back. And in such kind of drug patients, I actually ask that they come with a family member, maybe somebody's older, either a parent or an elder sibling. Maybe the drug patient is 22, 24. I ask for an older person to come, and I discuss with them as a group. There is straightforward explanation. If you have good success rate from your trabeculectomy surgery generally, and over time you have operated, you have that innate confidence to convince them. The alternative of not doing surgery is obvious blindness. The alternative for this case, if the child or if the drug individual, what he or she needs is trabeculectomy, not that the other options are still viable, either trabeculectomy or tube surgery. That's what this person needs. After we've ascertained that, then I will let them know, if we don't do this, the option is we are just waiting for you to get blind. However, if we do this, we improve the chance of you keeping your sight. Can I guarantee that you will keep your sight? No, but the success is there. And we also have patient association whereby they interact with each other. I send such patients to such association. We also have the counseling unit where we have trained our public health nurses on glaucoma care counseling, from the point of diagnosis to choosing options of treatment. We send such patients to them. So it's actually a holistic care approach to improve not just patient acceptability of the treatment option, but patient understanding of the disease, because patient understanding and buying into the disease treatment is key in actually the long-term success. So all those things are taken into consideration. Very educative, okay. Thank you very much. Is a family history parent with drug a risk factor? Yes, it is a risk factor. If a parent has glaucoma, even if it's poor, it's a risk factor. You know, I showed in one of the information regards to myocilin gene, about 10% of primary open angle glaucoma patients may have the mutated myocilin gene. about 20 to 30% in JOAG. So if it's a family, a parent that have that mutated multilin gene that is not transmitted to the child, of course, it's also important to have that. Great lecture. Thank you very much for the presentation. How would you manage a 10-year-old with an IOP of 10 and 11? Now, if the base IOP is 10 and 11 with a cup-to-this ratio of 0.7 in a 10-year-old, until proven otherwise, we should not jump and make a diagnosis of juvenile open-angle glaucoma in this individual. What is the disc size in relation to the cup and the vertical cup-to-this ratio? Most times you may be dealing with physiologic cupping. Remember, this same category of people may actually be also myopic. So we need to take that into consideration. When you have this kind of situation, you have to ensure that you exclude all other causes before you want to start treating a patient with 10 or 11 millimeter of mercury. And also understand that there is this inverse relationship with pressure in glaucoma and age. We tend to see that the older the person is at the point of diagnosis of glaucoma, the less likely he or she will have a higher pressure, a very high pressure. The younger the person is, the most likely that the person has a high pressure. So diagnosing glaucoma in the young age is more associated with high pressure glaucoma. Diagnosing glaucoma in older age is what you see more with lower pressures, maybe in 20s or even normal tension. And it's not far-fetched because the mechanical issue is more in the younger person. We know even this JOAG, and with the little explanation one has given, it's like a continuum or a straddler between PACG and POAG, whereby in the younger arm of it, it is behaving more like behaving more like primary congenital glaucoma. While in the older arm of the JOAG spectrum, is behaving more like the POAG individual. So I will not rush to treat this patient. I want to exclude every other possibility. Is it even a congenital anomaly of the disc size I'm seeing with this pressure? And it's rarely for you to see this pressure, this kind of copy in a 10-year-old, and it is glaucoma. It is rare, but we need to exclude other possible explanation first. Okay, from your experience, what has been the pressure drop in your cases of mix and over period? Practically, we don't do mix that much in our sense. We don't do mix. I can't say my experience. My experience is more with SLT in this JOAG category of individuals. And in terms of pressure drop, we only have between, on the average, about approximately 25 to 30% drop in intraocular. Success without need of further intervention, it's put around 50 to 60% of the case series we have generally. We may look at even reporting it very soon. Thank you very much for the educative series. From your experience, how do you distinguish JOAG and POAG in a 35-year-old patient with IOP of 30? If I'm seeing a 35-year-old IOP of 30 and have glaucomatous damage of the optic nerve head, I'll place my diagnosis as juvenile open-angle glaucoma. Because, you know, we can stretch the age limit to 39, so this falls in that bracket. But even if I want to keep the age limit at 35, for me to see this person at that 35 means that the glaucoma started before the age of 35. So it is JOAG. This is a word. Okay. Thank you. I think those are all the questions. Thank you. I don't know if there are any other ones that we answered. Okay. Dr. Sadiq and Dr. Tokumbo.
Thank you so very
I'm
much,
through
sir.
with the question.
Dr.
I think
Sarimi,
Dr.
please.
Sadiq network is poor.
One more question just came in. Dr. Sarimi, sir.
Okay, let me see.
Yes.
Sorry, Dr. Sadiq, there is one more question. Does it mean that JOAG... Sorry.
But there's one.
Sorry, does it mean that JOAG pressure must be high? Is there any place for facing? Of course, ma, there's place for facing, but yes, there's place for facing, there's place for water drinking test. One behavior about JOAG patient too, they have a very labile pressure. You may measure pressure at 10 a.m. and you are getting 19, and by 1 p.m. you are getting 29. That very labile nature is also one of the characteristics of them. Their fluctuation, diurnal fluctuation is very high. So facing is important. Even water drinking tests to abridge the waiting time for facing can give you an idea. But what I'm saying is because of the relationship between age and pressure, the younger the JOAG is, the less likely you are going to make a diagnosis of the subset of maybe juvenile normal tension glaucoma. Very rare. Even in reported cases, there are just very few clusters of families that they have reported that they have this juvenile normal tension glaucoma. And that is with extensive investigation to rule out all other possible causes and extensive follow-up to show truly that there is progression even at that stage of the intraocular pressure. So it's not a common thing to see normal pressure JOAG. You have to really be sure. And one way is to do your facing or water drinking test to actually pick out the off-clinic period rise pressure, which will now give you a better picture you are dealing with JOAG, or to monitor closely and you are not just looking at a variant of a normal disappearing with a cup, large cup. Thank you. Dr. Tokumbo, continue. I think I'm through.
Yes, you are. Thank you so very much, sir, for the brilliant webinar and for answering all of the questions. I think I'll hand over to Professor Lawoye if she's here. Or if she's not here, I'll hand over to Professor Oyesuku just to make some closing remarks.
Okay,
And then
thank you very much.
Yes, I'm here. Let Professor
Yes,
Oyesuku
I
speak.
wanted to say that I saw you. All right, you can continue.
I think she has asked Professor Oyesuku to continue.
Yes, she did.
I heard her voice. She was not around, so I was supposed to stand in, but she's around now, so she can continue. Professor Lawoye, are you on?
Go on, Professor Oyesuku. I'm in a very noisy place.
Okay, sorry. All right, thank you so much. Thank you for the webinar, Dr. Sarimi. Excellent job as usual. Thrown more light on juvenile open angle glaucoma. And thank you. We have 123 people. At the time, it was even 150 something. So that's a great turnout. And I'm sure we've all learned a lot. And just to let you know that we still have series of webinars that are going to go on tomorrow. Tomorrow, Thursday, Friday, and Saturday, and we really love for everybody to tune in and come and learn about the actual, secret behind trabeculectomy, how to get a good trabeculectomy from the pre-op all the way to the post-op management of these patients. So we hope to see you tomorrow again. The Zoom links are on the platform. We're still going to keep spreading it around. Thank you for all the questions you brought, and thank you so much for turning up. I don't know what else to say, but we are so grateful from the Glaucoma Society of Nigeria and the EXCO. We are grateful for you, using your evening that you would have used to do other things to come and listen to us. And we hope you really learned something from this webinar. So until we see you again tomorrow, we do hope that you have a pleasant night. Thank you.
Thank you. Thank you.
Bye. Yeah.
And bye.
Thank you, my teachers. Thank you, everyone. Thank you.
very
Dr.
much.
Yeah, thank you
Thank
very
you.
much.
Thank you.
Bye.
All right. Bye.
Excellent job. Excellent.
Yeah.
Excellent.
Dr. Bajolowo, you didn't let me say anything. Dr. Bajolowo, you didn't let me say anything. You took over my job. Thank you very
I'm
much.
so sorry.
Thank you
Oh, my
very much.
goodness. Our CME director. Please,
Hey,
ma.
that's Professor Reggie.
Thank you for
You
organizing
usurped
such
my
an excellent
you usurped my duty, and
No,
I
we're
think it is
allowing you.
unfair.
You know you're supposed to be resting. We don't want to disturb you.
Resting from what? So where am I
I'm so
joining? Do you know
sorry.
what time it is? Where I
Yeah,
am?
go back to the wedding.
We see
Well
that for 1
done.
year.
You,
She's on a honeymoon too.
do you know what time it is? Where I am? I joined this for a purpose, and you've
Oh
decided,
my
Dr.
goodness.
Saramiye, thank you very much for this.
Thank
Thank
you.
you,
Thank
ma.
you, ma.
Thank you for the
Thank you
opportunity,
so
ma.
much.
Thank you, ma.
Professor Morgan, apologies on their behalf.
No,
Yes,
I
ma, I'm
don't accept
apologizing.
Bajolowo's apologies. Bajolowo should have
Apologies.
known. I am there.
Apologizing on her
So
behalf.
sorry, ma.
Apologies.
My sincere apologies, ma. My most sincere apologies.
All right, so thank you.
Yes, ma'am.
Bye.